Okay. I guess we're kind of ready to get started. Okay. Um, Sorry everyone, we had to move this online last minute. I was still hoping to do some of this in person, just to have a little bit of in-person interactions as well. But we're going to be going back to the hybrid option again next week. So there is that. But for this week, we actually have Shane Eaton, who's going to talk about the applications of AI in neurology and neurosurgery. I forgot doctor in the beginning, Dr. Shane Eaton. He is a neuropathology resident at the University of Toronto, and he is one of the co-founders of AI in Medicine Student Society, which has brought you this course. In fact, he actually interviewed me himself for the role of president.
You're
So
doing a great job.
thank you so much. Okay, and with that, I guess I will hand it over to Shane to tell you a little bit about applications of AI in neuro. I have seen some of these slides. They're actually really cool. So I hope you enjoy.
Okay, hello everyone. So I'm going to talk about what is neurology and what is neurosurgery and what are some of the applications of AI in those fields and what we can look forward to in the future. So by the end of this talk, hopefully you'll understand the scope of neurology and neurosurgery, be able to provide some examples of how it's being used, and talk about how it might transform the future. And this is just a brief outline of what we're going to talk through, and you'll see as we go. So first, what is the nervous system? I might ask the audience. I'm sure everybody knows, but anybody want to offer an answer? I'll monitor the chat. Easiest question in the world, because you all have one, and you're using it to answer the question. I see
So,
a hand raised.
yeah, I'm going to try. The nervous system is like the brain and the spinal cord and all the nerves that connect the different regions of the brain and different regions of the brain and spinal cord.
Perfect. See, that was very easy. As you can see, this, just as he said, we have our brain protected by our nice hard skull, and it sends most of its inputs and outputs travel through the spinal cord, and the spinal cord sends off multiple nerves to innervate our entire body. And muscle is sometimes included under the umbrella of the nervous system, just because the nerves themselves actually synapse directly onto muscle. So in neuropathology, that's pathology of muscle is covered there. So the brain, you're all using it, hopefully it's going in overdrive, burning lots of glucose today. Its main uses, as you are well familiar, is for sensory processing, motor control, like moving your hands, your legs, everything. It's the seat of consciousness and thought. But what is consciousness and what is thought? Nobody really knows yet. And it's also very highly vascular with very complex regional anatomy. So this is just a small sampling of some of the complex regional anatomy of the brain. In a lot of the other major organs of the body, like liver and kidney, spleen, this part over here is the same as this part over here. In the brain, this part controls vision, this part controls balance. This part is where you do some of your thinking, and this is one of the parts that stop working if you drink a little too much. So stay focused. Then similarly, the spinal cord also has a complex regional anatomy, but it's not just a transmission cable. It also has some built-in processing and functioning that the brain has nothing to do with, like reflexes. If you tap your knee and your leg kicks out, that's spinal cord only. It doesn't go to the brain. It sends a signal like, yeah, we've seen this is happening, but the brain isn't involved. Similarly, walking. That's why you can do so many things while you're walking, because it's all automated within the spinal cord, and that frees up your thought and everything else while you're walking. Again, complex regional anatomy. Blue is where it's sending up to the brain. Red is where it's sending out to all the muscles and things. So it's a very complicated part of the body, a very complicated part of medicine, and we need more AI to figure it out. And so finally, peripheral nerves, probably the simplest of part of the nervous system, collects all the information from your vision, your nose, your ears, all the skin all in your body, touch, as well as the lesser known senses of balance and proprioception. So proprioception is the position sense. Like if you close your eyes and move your arm, you know where it is. Without proprioception, you have no idea where it's been moved to, or if it's been moved at all. And there's also some autonomic control. There's peripheral nerves that innervates all your organs, and they're partially responsible for some of those rest and digest or fight or flight responses. So neurology and neurosurgery fall under the umbrella of clinical neurosciences. And neurology is the medical management of disorders and diseases of the nervous system. So anything that you can't surgically address, you use neurology, as treatments are often like medications or fluids, a variety of other rehabilitations, all trying to minimize the effects of a neurological disease. Neurosurgery is where you actually open up the body, access the nervous tissue, and in some cases you remove a tumor, other cases you stimulate nervous tissue. And the related disciplines in the clinical neurosciences are radiology. This is huge in AI, image recognition and radiology, as well as neuropathology. It's also looking at image recognition, and physiatry, one of the lesser known. That's like it's kind of like a physiotherapist who's also a doctor, and they do a lot of rehabilitation of spinal cord injury or stroke patients. And finally, psychiatry, which is converging more and more with neurology and neurosurgery as we begin to understand more and more of the software of the brain. So again, I'd like to ask the audience, what disorders come to mind when you think of neurology? Like what's a neurological disorder? Anybody have any examples? Throw it in the chat. Or MS, yes. Multiple sclerosis. Dementia, yes. TIA, yes. Transient ischemic attack, it's like a mini stroke. Tourette's, yes. Not just like an outburst of behavior, it's actually a movement disorder. Schizophrenia, yes. Schizophrenia is currently under psychiatry, but that can be, again, as I said, that's converging. Cerebral abscess, good one. Okay. So neurology, some of the general ones, more common ones you see are headaches, strokes, brain tumors are quite common, seizures, epilepsy, movement disorders. We had Tourette's mentioned, also Parkinson's, Huntington's. Parkinson's is when you have less movement, people get stiff and they shuffle around. Huntington's is a little bit more movement, called the chorea, where they uncontrollable motions. Dementia, there's various types of dementia. Alzheimer's is the most famous. And there's also autoimmune neurologic disorders. Multiple sclerosis is one of them. ALS, formerly known as Lou Gehrig's disease. That's one of the more famous autoimmune neurological disorders, where it attacks the motor neurons in the spinal cord. And Guillain-Barré syndrome, this is another one that sometimes is a reaction to certain viruses, where you can be like temporarily paralyzed for several weeks, but usually you have a full recovery. And this is just a small sampling. And some of you in medicine might recognize this guy over here. He's an ophthalmologist that does a lot of comedic YouTube videos, and this is his neurologist character. So we'll come up later. Dr. Glockenflecken. Okay, so we did neurology. How about neurosurgery? What's a disorder that you think of in neurosurgery? And why is it different from neurology? We had one mentioned already that's more neurosurgery, the cerebral abscess. Neuro-oncology, yes, tumors, cancers. Intracranial pressure, yes. When the pressure builds up in the brain, you need to relieve it because the skull has no room to grow. Unless you're a child and the bony plates haven't fused yet. Essential tremor, ukodwan. You read my mind. Okay, anyone else? DBS, yes, good. Deep brain stimulation. Lobotomy, not anymore. Okay, neurosurgery. We had a lot of these mentioned. Some of the intracranial in the head. You have like hemorrhages. If you have a car accident, you can have a bleed in your between your brain and the skull. That the pressure starts to build up. That needs to be removed. Brain herniations also caused when the pressure increases. Tumors, aneurysms. That's another one that can happen when the blood vessel starts to swell and almost burst. In the spine, trauma, spinal stenosis, disc herniations, a lot of bad backs out there, so sit up straight. Peripheral nerves, similar kind of thing, trauma, reconnecting them. And there's one nerve ablation where if you have a nerve that's decided to become very irritated and just constantly transmit pain signal, then they'll often, in extreme cases, they'll actually just destroy the nerve itself just to stop the pain. And then deep brain stimulation falls under functional, where you use it to treat epilepsy or movement disorders. And then here's Dr. Strange, the famous, the marvelous neurosurgeon. Okay, so when a patient comes into neurology or neurosurgery, often they present with some kind of symptom. They go to their family doctor, and then they get sent to do a variety of tests. They might get a biopsy, they might get imaging, they'll do like a full physical exam, collect all this data, collect multiple blood tests, and all that information gets fed to figure out what the diagnosis is. And then they may go on to surgery and get treatment, and then you initiate a management plan. And in some cases, there is no management, in like severe brain cancers, where then you go to prognostication, where you have to figure out, okay, given all these symptoms, how long can you say this patient is going to have to live? And then finally, prevention. If you have something that can recur or remit, maybe there's some strategies you can take to prevent it. So there's a lot of opportunities to optimize neurological or neurosurgical treatment in this pathway, and we'll just mention a small number of examples. Some of the data that comes into neurology and neurosurgery, a lot of images. This falls under radiology, like MRI, CT, PET scans, even just like photography or video, especially with the movement disorders. Important thing is to watch how people walk. You can often come up with a fairly good diagnosis just based on how they walk. As well, and there's a lot of electrical signals as well, like EEG recordings. This is a picture of some of the EEG electrodes. I actually have my own wireless EEG headset to play with. They're spiky electrodes, so it's a little ticklish. But you can collect a lot of electrical data through the skull. But if you want really precise data, you use ECOG, which is electrocorticography. That's where you have electrodes surgically implanted on the surface of the brain, on the cortex. So you might have seen Elon Musk's Neuralink, where he's optimized the electrode size and implantation of those electrodes on the brain. And then similar to other fields of medicine, we can look at genetic information, try and figure out what gene is causing this, or maybe there's a combination of genes that are causing it. What's in the blood that we can detect, and you can do cognitive testing as well. So this, as well as all the other medical data, all goes into figuring out what is going on and how do you treat it. Then I just wanted to mention a few other aspects of neurosurgery. Everybody's familiar with when you open up the skull, you poke around with sharp metal tools. Everybody knows that. There's also microsurgery, where it's the same as classical surgery, but you just have a microscope and it's very tiny, fine tools, much more difficult. And that's where you might need a robot to assist you that doesn't have any hand tremor. So there's the Da Vinci robot that filters out hand tremor, used a lot in surgery. There's endovascular surgery, where you feed a wire up the arteries in your leg all the way up to the brain, and then you can add a little aneurysm coil or clip an aneurysm. Usually it's vascular disorders that they do that, but you can access the brain without even opening the skull that way. And a couple other ways you can do it without opening the skull is the gamma knife, which uses gamma ray radiation focused to a tiny point in the brain through the skull. They do this for if you need to like ablate part of the brain. If you have like a focus of an epileptic focus, for example, part of the brain that's just firing out of control and causing seizures, you could potentially ablate it with the gamma knife. Or you could do that to those painful, noisy nerves that I mentioned before. And the newer one is focused ultrasound, which can do the same thing that the gamma knife does, but without radiation. However, currently the resolution is much, much lower, so you don't have the same precision yet. But we're getting there. Okay, now into the AI. I'm going to cover a few applications of AI in neurology and then in neurosurgery. So this is coma. It's a paper published in 2019 called The Outcome Prediction in Post-Anoxic Coma with Deep Learning. So the problem is, you have someone in a coma, how do you know if they're actually in a coma, or are they brain dead, or if they are in a coma, are they going to come out of a coma? They can't respond, the patient can't respond, so you need to figure this out. So they took EEG recordings from a large number of comatose patients. These are like post-cardiac arrest. So this is where brain starved of oxygen for a while, just went to a coma. This is an example of some of the EEG recording that you might get. It's like each one's a different electrode placed on a different point of the skull, and so you can try and figure out the picture of what's going on based on that. The model they used was a convolutional neural network, and the results were that they were able to more accurately predict the outcome compared to trained neurophysiologists that look at these scans, and in much faster time. So I want to ask, what is the usefulness of this? One of the big problems in AI papers and AI research, especially in medicine, is, okay, we did a cool thing, but is it useful? So I want to see what the audience thinks. Is this useful? What is it useful for? Anyone want to offer their thoughts? Reliable answers without subjectivity. Okay. Saves doctors time. Yes, that's always good. Elimination of human error. Yes. Assuming human error didn't go into the training of the model. Okay. All right, so we had a couple answers on why it's useful. We'll give something a bit more tangible to tell the family. Oh, that's a good one. ICU beds are very expensive. Yes. sometimes it's thought that we shouldn't be thinking about money, but we have to think about money because that's what makes everything run. Not enough doctors. Good. Okay. So outcome prediction with coma. Yeah, you have to. The two big ones that I heard are, hospital beds are expensive, and there's other people that need them too. So if you know that, if you can predict that, okay, they're not going to recover, then that can go to the bed can go to someone who can recover. And being able to tell the family, are they going to come out of this? What's the hope? So coma prediction is valuable. It can help appease the family and as well save money. Okay, next one. Migraines. Is video playing? One moment. Minor technical difficulty.
You're muted.
Thank you. Okay, migraine. It's a common headache that a lot of people get, and if you've had one, you might recognize the aura that often precedes it. It's a video of what that looks like if you haven't ever experienced this before. One of the problems with migraine is that you take medication to treat it, and if you get a pretty bad one, then you'll take a little bit more to treat it. And if you make a habit of that, you can start over-treating it, where now the medication itself is causing a new migraine, which then that causes the patient to take even more to continue to treat it. So you have to find the right balance of medication. And there's a large number of migraine patients that are suffering from overuse patients. So how do you identify them? And this paper used machine learning to predict medication overuse in migraine patients. And they looked at 777 patients with migraine, and 167 of them had confirmed overuse headache. And they looked at all their demographic data, their clinical histories, biochemical data, so their blood tests, to try and predict who's most likely to be having this overuse patient, or this overuse headache. And they used a simple support vector machine, which is just a glorified regression. And results were that they're able to predict with 87% accuracy. Now, I don't know if this was talked about in the course before, but what's the problem with the accuracy measure of efficacy? Anyone want to offer an idea? What's the problem when you see accuracy reported? It's not useful if the data is unbalanced. Yes. So if you look at the data here, 77 patients and 167 have overuse headache. If you label all of them as not having overuse headache, then you're already getting pretty close to 87%. You're just more around like high 70s, about 80. So if you look at that alone, it may give you a false idea of how effective this is. So they also report the area under the curve, which is more reliable at 0.83. So that accuracy with the area under the curve is much more convincing. So again, what's the utility? Why is this useful? Anyone want to type an idea? No? Okay. So if you can automatically identify who's having overtreatment headaches instead of migraine, then you could potentially scan health records and flag patients that are at high risk for medication overuse headaches. And then the doctor can go look at their file and look at their medications, and maybe they need to have an adjustment or mark down the next time they see them, okay, we'll talk about medication overuse. And this saves both the patient and the healthcare system a lot of money and suffering. Because if you can stop taking the medication so much, optimize the treatment, then headaches resolve, costs less, you don't have to pay as much for the medications, and there are fewer repeat visits to the doctor to try and solve the problem. So this one could be quite useful. Okay, next. Now we have stroke. Stroke is very, very common. And the problem with stroke is that time is brain. The moment you have a stroke, part of the brain is starved of oxygen. And the brain can hold its breath, so to speak, for a little bit of time, but every second that passes, more and more brain is lost. So time is brain in stroke. One of the challenging parts of stroke is that you can have two types, hemorrhagic versus ischemic. Hemorrhagic is where it bleeds into the brain. And then instead of going to the tissues, it kind of surrounds and chokes out the tissues. In ischemic, then the blood supply is blocked and they're not getting a blood supply. And the problem is the treatment for hemorrhagic can cause ischemic stroke. Treatment for ischemic stroke can cause hemorrhagic stroke. So stroke is very challenging to treat. So they want to see if they could very quickly figure out what kind of stroke is happening in the brain. And there's some new ambulances that will have a CT scanner within it, so that they're stroke ambulances, so that you can get these images immediately. They looked at aspect scores, and this is a type of scoring developed in Alberta. They look at particular parts of the brain to identify areas of stroke. Usually these darker areas are where there is stroke. If you're not used to seeing these, it can be very subtle, but they want to use the image segmentation to identify these very quickly. And they use a convolutional neural network to do this. And the result is that they can do automated scoring with this aspect score, and it's very comparable to radiologist scoring. The added benefit is that you don't have to wait. And again, for utility, how will this help? Is this useful? Again, any ideas? Please put into the chat. And just looking at the chat, there was a question I missed. Just wondering if the study was looking specifically at overuse of acetaminophen and NSAIDs, given that they're most typical for overuse headaches. No, they didn't distinguish what type of medication was being overused, just if there was overuse. But by and large, it is NSAIDs and acetaminophen. Okay, so this one I would argue is one of the more useful applications of AI in neurology, because time is brain, and if they can automatically figure out what kind of stroke this is immediately, like without having to wait for a radiologist report, then you can start treatment immediately, and that could potentially be the difference between someone that's disabled for life and someone that can just recover and rehabilitate and as if nothing happened. And now the last one for neurology is Parkinson's. So this one, they use a vocal feature extraction to detect Parkinson's disease. So this is a picture of someone with Parkinson's. This is the classic stooped posture. Their motion is very stiff, almost shuffling, and they have a lot of trouble changing position. They're very slow to do that. If once you know what to look for, it can be very obvious when someone has Parkinson's. But this is more advanced. So how do you detect it? Can you detect it earlier? And if you can detect it earlier, you can treat it earlier. So they looked at 188 Parkinson's patients, and they took 3 voice recordings of each one. And you're wondering why voice? If their problem is walking, it's why voice? Well, the problem is movement, any kind of movement. All your muscles are affected because it's the brain controlling the muscles that's affected, and you need all your muscles to speak. So if you're having a difficulty using your muscles, that might be picked up in the voice. Here they used an SAE SVM. It was just a pre-feature extraction before applying to SVM. And the result was, with 93% accuracy, they could detect Parkinson's. And this I thought is that this could be incorporated into like a wearable, like your phone, or anything on you that has a microphone that could potentially be listening, and it could alert you to, hey, abnormal voice patterns detected, go see your doctor, or something like that. And again, is this useful? What's the benefit of this? Again, always early diagnosis, good, be able to identify and treat early. Yes. Earlier preparation for the family to deal with it. Yes, very good. Yeah, so if you can detect it earlier and detect it more automatically, then you could be helping a lot more people. Well, for one, just detecting a lot more people. Some people won't even go to the doctor. They might just live with it and just deteriorate unless something alerts them, especially if they're living on their own. And yeah, non-invasive, cheap. Yes, cheap is good. Money rules everything. So if you can save money, then you're good. And yeah, the family, that's a big one too. If the family knows about it, they can make plans, they can put in supports around the house if needed, and they can figure out who's going to support the person with Parkinson's as the disease progresses. Parkinson's is awful. Yes, agreed. Okay, so that's it for 4 interesting examples for neurology. Now I'd like to talk about 4 examples of AI used in neurosurgery. Okay, so this one is functional monitoring during surgery. So the title of this one is Deep Learning for Automatically Visual Evoked Potential Classification During Surgical Decompression of Cellular Region Tumors. So the cellular region it's right at the very base of the brain. Down here, this is your sinuses here, and up here is your brain. And this is where your pituitary gland sits, right in what they call the sella, which is Latin for saddle. And so that's right here. And what is just above this region is the optic chiasm. This is where your two optic nerves meet up and then cross. So it's a very delicate region for surgery, because if you damage the optic nerve, you could blind the patient. And that's very easy to do accidentally. So the idea of this one is how can we automatically monitor the integrity of the optic nerve while we're doing the surgery? So for this, they looked at 76 patients with cellular tumors, and they recorded visual evoked potentials. And what this means is they had electrodes at the back of the brain. Back of the brain is the occipital cortex, or the visual cortex. Right at the back, that's where all your vision processing goes. So if you have damage at the back of the brain, you could go blind. And they had electrodes there, and they were applying flashes of light to the eyes. And they're monitoring the electrical response with each flash at the back of the brain during surgery. And they used a convolutional neural network and a recurrent neural network. The thinking was recurrent neural network is more useful for the dynamic nature of the data. And the result was, it was just comparable to human interpretation. So no better, no worse, but automated. Again, is this useful? Again, feel free to add your thoughts in the chat. But yeah, this frees up if you don't have to have someone constantly monitoring or reading, you can have an automated live readout of how well the optic nerve is functioning. So as you're poking around there, sometimes the tumors can push on the nerve, sometimes the tumors can surround the nerve, and you need to carefully remove it. And if you see a change in that signal, then you know to back off. So this could save time. Next one. Again, the video is not playing. But this was going to be an example of essential tremor. So give me 1 second again for the technical difficulty. Okay, so this paper is looking at deep brain stimulation for essential tremor. And this video is not from the paper, but it's an example of essential tremor. And you'll see at one point they'll turn on the stimulator, the deep brain stimulator, and the tremor will disappear. So these deep brain stimulation, you have an electrode implanted into a particular part of the brain that's causing the tremor. And it's been activated and your tremor's off now. But you insert an electrode in part of the brain, and you have continuous stimulation of that part of the brain in order to dampen the the abnormal signal. And the problem with that is, do you need it all the time? That uses battery life. What if the battery dies when you're in the middle of drinking your hot coffee? Then you burn yourself. What if the tremor comes and goes? Maybe it's not always that constant. And what about side effects of the stimulation? Like the brain's an intricate place, and if it's the goal is to stimulate just the tremor focus, but sometimes there's some spillover and you get other sensory or motor symptoms. So for this study, they wanted to look at how can you use closed loop deep brain stimulation that's recording as well as stimulating. So they used 3 patients, looked at electrocorticography, and they had them do 16 movements each. Notice the number of patients is very small here. That's because it's having an electrode array implanted in your brain it's a very invasive thing. Not everybody will consent to it. Not everybody needs it. So it's a small patient pool to take from. So they didn't really specify what model they used, but they said they used a binary classifier. So I guess any binary classifier would work. Basically, they were looking at, is there tremor or is there no tremor? So they found that there was just very slight improvement in tremor control when they were recording and feeding that into the stimulator. And it was just like on or off. Does it need to be on now? Does it need to be off now? And the results weren't the best, but it was a proof of concept. And maybe it will be further refined. So what's the usefulness of this? Is this one useful? If the stimulator works already, why do we need the closed loop? May have already said some reasons, but if anybody's got the other ideas, put them into the chat. Yeah, big one is saving on battery time. So stimulation can be delivered only when needed. Yes. Don't want to waste power. We don't want to stimulate when not needed. Yeah, so it's a small population of patients that need this, but it could potentially save them money in battery. You don't have to replace the battery as much or recharge it. More reliable. It'll be more reliable. They don't have to worry, well, how much battery do I have left? Am I close to my charger? And it can give them much more peace of mind when they can know they can rely on their device a bit better. Okay, now this one is an interesting one. This is assessment of neurosurgical skill using artificial intelligence and EEG to assess expertise of neurosurgeons. So this isn't looking at the patients, it's looking at the surgeons themselves. So they used EEG. EEG is very popular with AI during VR operations. So they had a combo VR EEG headset and a virtual operation, and they had 10 senior surgeons and 11 novice learners do this surgery while wearing this electrode VR headset. And they tried a whole bunch of different models and picked the one that gave the best result, which I think was the ANN. But guess what? The result was 100% accuracy, predicting surgical expertise. 100%. And not only that, but they did the area under the curve 1.0. That is almost unheard of. Anybody have any thoughts on that result? That's the result everyone dreams of getting with AI. Any thoughts on that? And lead into that, is it useful? all qualified people, improbable. Any other ideas? Any other thoughts? Questions of overfitting? Was there a wrong answer? Aha! Kent has the answer. I can tell apart a senior surgeon from a novice just by asking them, how many years have you done surgery? Yes. They basically found a way to detect who is a surgeon and who is not. So of course, if you're not a surgeon, your surgical skill is going to be terrible. And of course, there's going to be an obvious difference with an expert surgeon versus a total novice. So is this useful? No, this is not useful. But it is a proof of concept, and potentially they can refine it, and maybe they can determine whether senior surgeon A is better than senior surgeon B at some point. But is this useful now? No, because as was said, you can just ask them, are you a surgeon? So things to think about when you're thinking about your next cool AI project. Is it useful? And what is it actually predicting? And is there an easier way? Okay, the last one for neurosurgery. This is on image guidance. So image guidance is commonly used in neurosurgery. They do extensive MRI scanning beforehand so they can plan out their surgical route. And they also have like a guidance tool. It's basically it's like a stylus that with some motion capture balls on it, and they can touch it. There's cameras set up in the operating room, and they touch it to the skull, and the cameras are recording that and mapping it to an image of the brain on the screen. And as you move the stylus along the skull, it'll show you where it is on the actual MRI image on the screen. So that's very important for accurate neurosurgery. But there's a problem with that, because the MRI was taken either earlier that day or yesterday. And now they're put into possibly a different position. And like with every heartbeat, the brain is pulsing. And as soon as you open the skull, now you've created an area of lower pressure here, and everything will shift to that opening. So as soon as you start doing neurosurgery, your image guidance is no longer 100% accurate. And in the brain, a shift of a millimeter can mean like a big difference. 1 millimeter over, you're in be a difference from motor cortex to sensory cortex. So how can you adjust for that deformation? Is there a machine learning approach for that real-time modeling of that deformation? So here they used a patient-derived virtual brain mesh. So they took MRIs from tumor patients, and they converted those MRIs to 3D mesh, and they just looked at the overall brain shape plus the tumor shape. And then this is all in a virtual experiment, so they turned this into this deformation mesh, and they provided a variety of biomechanical stimulations, like poke or pull or squish. And they wanted to see which of the different variables of the tissue was important for what could be used to predict deformation. Again, they used an artificial neural network. And the result was that they found a couple of variables that could reliably predict tumor deformation based on a force. And what those variables are, I believe they're just like properties of the tissue itself. The tumor has different, like Young's modulus or something like that. The tumor itself tends to be more rigid and will deform differently from the brain, which is a softer tissue. So if they can input the shape, and provide the variables or descriptor variables of what the tissue is, how the tissue is going to respond, then they can use that to predict deformation. Again, is this useful? Certainly more useful than the last one. For this one, it is all about increasing precision. Brain is very complex, and the more precise you can be, the better outcomes can be. So if you can map this live while you're poking around in the brain, and it automatically adjusts to the imaging, then you're much more less likely to make a mistake. So this could be very useful. All right, so those are some examples of how AI is used in neurology and neurosurgery. And what do you think the future holds for neurology and neurosurgery? What's in your imaginations? Pattern recognition in EEG signals. Maybe after we save that for questions at the end. What chamber you could walk into, be fully diagnosed physically and mentally? Oh, that's medicine as a whole, but what about neurology and surgery specifically? Single consultation, patient can be diagnosed and receive treatment from AI. Yes, these are all ideals. Okay, so neurosurgery and neurology are still challenging fields. We don't know a lot about the brain. We often can't do a whole lot when there is a problem. So there's a lot of areas for improvement. A lot of them are just medical as a whole, like symptom monitoring and control, drug discovery, risk stratification, and prognostication. Early disease detection, we saw an example of that with Parkinson's, and then automated MRI, EEG analysis. This falls a lot under radiology. Radiology is the one that's going to be transformed first by AI. But we need to address all of these. Neurosurgery is going to be a big boom in neurosurgery. With improved surgical precision and speed, there are neurosurgical robots now, and it's now this concept of human-robot collaborative surgery, where human does one thing, and then the robot automatically does some mundane thing like suturing, and then passes back off to the human. Human does something or positions the robot, and then the robot performs the task. So that's going to be coming soon, before it's fully automated, and there's going to be augmented reality as well. In this video, they have an augmented reality headset to map an MRI of someone's spine onto the patient itself as they're doing surgery, so they can see where the spine is in real time. But if you notice, it's kind of jittery. You don't want jittery when you're poking around in the spine. And this is an image of image segmentation during a abdominal surgery, where it's highlighted the gallbladder and the liver and the surgical tools. So this on a much more precise scale could be used to identify parts of the brain during surgery. And next big thing, and my favorite, is cyborgs, smart prosthetics, and implants. So this is a video from last year, and they're using AI and spinal cord stimulation to allow someone to walk again. And I'll just play that now.
2 years ago, we developed an intervention based on electrical stimulation of the spinal cord that enabled David to regain walking after years of paralysis. Today, we develop new technology, more precise, that allow us to address the deficits of individuals with complete sensory motor paralysis. So we've designed a completely new electrode array that is wider and longer. I could implant this electrode array just under the vertebra and upon the spinal cord, and with this technology, we could access a broader region of the spinal cord in order not only to activate the leg muscles, but also the trunk muscles. We stimulate the spinal cord with spatiotemporal stimulation pattern that reproduce the way the spinal cord is activated naturally by the brain. And to do so, we have a mini computer that the patient can carry with him and that deliver the stimulation and adjust them, synchronize them with the ongoing movement. This technology is so precise that immediately after the surgery, the patient can walk and stand. But in order to use it outdoor, he needs to train to come with us, and it will take some more time.
I did an accident on motorbike. An animal across my road. I immediately understand that something wrong happened. I tried to move the legs, tried to change my position. I see that was impossible to do nothing. I fixed in my mind that was just a situation. So I put all my mind, my behavior to try to solve this problem. And I never stopped. I tried to do a lot of things that can help me. So I put all my session training and my help also to be in a good physical situation to be a patient for this problem. At the beginning, I was a little bit scared, but when I talked with Josephine Block and Cleber Time, as they explained me how easy is it the surgery, I see exactly how is it the movement of the implantation. And after this, I relax a little bit. You told your mind, okay, now you start with the left side, the right side. Yes, and then you push and you start to walk. Every day I walk around 2 hours. Now my training is to improve the quality of the step, to be more fluid, and also the speed. For the moment, I can walk 1,500 meters. I got to reach 1 kilometer for the summer. Walking is super important. Just stand up can solve a lot of kind of problems in the normal life. Just to do a simple shower with a crutches, I can stand up and do a shower. With the walker, I'm free. I can walk wherever I want. At this moment, told me, okay, now I'm working.
There are so many patients around the world who need a treatment to fight against paralysis. We have reached the point where we are ready to develop this treatment. It's why we are collaborating with Onward Medical that is developing all the technology to turn these results into a treatment available throughout the world.
So, hope that was an inspiring video on what's to come. That's a year ago, so now they're working on a much more refined version that also stimulates the trunk muscles for stabilization. So we're going to see some interesting cyborgs coming soon. So, is everyone excited for future of AI in neurology and neurosurgery? Seeing some yeses. Correct answer. And there's a lot. It's a very, as much as we know about nervous system, we know very, very little, and AI could do a whole lot to help. So we're going to see some exciting things. Well, we could screw it up and make things worse. Yes, but that's true with anything in life. You can't think of the screw up. You gotta go for it. Minimize the screw ups, but go for it anyway. Okay, that concludes my presentation. Any questions? Was it clear? Anything else I could explain? I'll put on my thinking cap. Great thinking, Cap. Thank you. I like it.